agenda, as I said, I'll talk a little bit about Norway. I will talk about the Norwegian brain metastasis study, and then screening for brain metastases and pros and cons for that. Next one, please. I will only see a picture of Kasia.
Olav, can you see the screen transitioning here or no?
No, now I only see you.
Oh, okay.
Your picture.
Okay, so let me share one more time.
There we go. So if you can go one, yeah, that's great. One more back. And one more forward. Okay, here we go. So Norway is based on top of Europe, as you probably know. We have the island of Svalbard just up in the Arctic. The blue line represents the polar circle, and the green line represents the level of which Toronto would be in Europe. It's in the south of Europe. And Norway borders to Sweden, Finland, and Russia. Next one, please. So we're just not only a nation of football and rowers, we are also a nation of ice hockey, for some of you who are interested in that. I was advised not to show you that picture, but I'll do it anyway. Norway is a very long country. We're a population of merely 5.5 million people, but it's a long country, almost 1,100 miles long. And I try to compare that to distances in Canada. So if you take the next one, Kasia, if you take the same distance from Toronto by air, you end up in Yorktown, Saskatchewan, if you want to go there. So that's just to put it in perspectives. Next one. I'm based in Oslo, which is in the southeastern part of Norway. And my hospital is in the next slide. So this is the Norwegian Radium Hospital. The circle in the middle, the small circle, is where we have our palliative care ward. In front there, you have the radiotherapy center, which also contains a proton therapy unit. We have a research building, basically doing basic research and translational research. And on the right on the screen, you see a high school combined with the pharmaceutical industry and the Norwegian Cancer Registry, which has records of every cancer case in Norway since the 1950s. And the arrow is on the oldest site of the hospital, which was opened in 1932. So in the upper right corner, you now see the old building when it was opened. Next one. This is a view from our brand new ward. It was opened just more than a year ago. So you can see the fjord of Oslo in the back there. Next one. So regarding the brain metastases, which has been my interest of research for the last couple of years, we did a quite large project containing several work packages. I was the lead of the VP1. This was the prospective cohort study. Next one, please. And it was in the auspices of the European Palliative Care Research Center, of the PRC, where we are focused on patient-centered care and how to integrate and implement palliative care in health services. Next one, please. And trying to find a fancy name for a study is always hard. So we were trying to name the study of the Norwegian Brain Metastasis Registry. And then one suggestion was to do like this, if you do the next one. So the no-brainer alternative did not find any reception, so we decided to drop that. And the name became, as you will see on the next slide, the Norwegian Brain Metastasis Study, a really original title. The main results were published in the Lancet Regional Health Europe in February last year. We had a little more than 900 patients. The median survival was 5.9 months, but as you can see, with a very large range in survival, and several patients are still alive more than 10 years after inclusion in the study. And as you know, the treatment options for brain metastasis are generally the same as they've been for the last 20 years. It's surgery, radiotherapy, either in the form of stereotactic radiotherapy or whole brain, systemic treatment, and best supportive care. And as you can see, most of our patients were treated with radiotherapy, which was due to the inclusion or recruitment strategy, which mostly concerned patients referred for radiotherapy. The most interesting part, I think, if you go to the next one, those who were treated with stereotactic radiotherapy, the fear for my colleagues was that doing stereotactic would only delay the need for whole brain radiotherapy. But as you can see, only about 10% of the patients were actually in the need of whole brain later on in their disease, meaning that stereotactic radiotherapy can be a very well-suited alternative. This is survival according to initial treatment. And I think this basically shows that we were quite good at selecting patients for the right treatments. The longest survival for the surgery-treated patients and shorter for whole brain and best supportive care with stereotactic radiotherapy and systemic treatment somewhere in the middle. Next one. And by primary cancer, the breast cancer patients did best with a median survival of 12.8 months, basically related to the superior effect on extracranial disease. The worst off were the colorectal patients with only 3.6 months of median survival. Next one. What we did see was, or confirm, was the known prognostic parameters from earlier studies. So this is just illustrating patients with a high tumor load, more than 4 brain metastases intracranially. And as you can see, the survival is highly dependent on the performance status. So those with ECOG 0 to 1 do better than those with ECOG 2 to 4. But it also depends on the control of extracranial disease. So as soon as you don't have control, or you are more than equal to or more than ECOG 2, you have a very worse prognosis than if you are in a better performance status. Next one. So we decided to look further into the patients treated with whole brain radiotherapy, and the median overall survival, as you just saw, was just about 3 months, but again with a quite wide range. So some people are still alive more than 12 months after whole brain radiotherapy, which means that you have to follow up these patients very carefully. Next one. And also here we could see that the survival was highly dependent on the performance status. So the patients with the best performance status of ECOG 0 did fairly well with a median overall survival of almost 10 months. But as soon as you go down to ECOG 1 or worse, the survival really drops. And quite surprisingly to us, the ECOG 2 patients did as bad as the ECOG 3 to 4 patients, indicating that ECOG 2 is a risk factor for poor survival if you are only eligible to whole brain. Next one. And I will illustrate that by a patient that had a blog on the internet, which I just coincidentally came over. This is a woman from the US. She had all the good prognostic parameters. She was young, she had breast cancer, controlled extracranial disease, and a pretty good performance status. She had whole brain radiotherapy in July 2016. And in her diary, she wrote that 2 weeks after radiotherapy, she was extremely fatigued, very tired, and had a hard month. Her last entry was unfortunately in January 2019, and she passed away in April the same year. Next one. So we also saw this pattern looking at patients according to their ECOG status after whole brain radiotherapy. We asked them using certified quality of life questionnaires. And as you can see, the physical function after whole brain drops mostly for the ECOG 2 patients, but also for the ECOG 0 and ECOG 1. And accordingly, the fatigue levels rise pretty much also for the ECOG 0 and ECOG 1 up to 2 months after therapy. So even if you are doing very well before whole brain, you must be able to cope with the extreme fatigue and the drop in physical function after therapy. Next one. We also saw this based on survival times, where we separated the patients according to how long they were alive. And there seems to be a line between 6 months. So the patients that survived less than 6 months really dropped in physical function up to 2 months after diagnosis. And the fatigue levels also rose quite steadily, whereas those surviving more than 6 months did quite stabilize in their physical function and their fatigue levels. This means that you need to consider both the survival prognosis and the performance status of the patient before you offer them whole brain radiotherapy. Next one. We also did a long-term follow-up of the patients surviving more than 2 years. So we took them into cognitive testing and interviewed them. And I'll just briefly show you the results from that. Next slide. So patients with brain metastases are always concerned about their memory and the memory loss. And surprisingly, we found that the tests for memory were as equal to or even slightly better than the normal reference group. Those are the tests that you can see in the upper square panel. What was really also illustrating was that the test that I did worst performance was tests for executive functioning, planning, and flexibility. And these are capabilities important for planning and executing your daily activities, which is more of the problems that these patients really face. So you can kind of assure them that their memory will be fine, but their capability to do things will be more restricted. Next one. We also did an interview study asking the patients and their next of kin how they experienced having the brain metastasis diagnosis, the information they received, and their follow-up. And what separated the patients from the carriers was that initially the patients also thought having brain metastasis were a catastrophe, mostly when they were diagnosed at the same time as their primary cancer. Those who had a longer disease trajectory beforehand, who were used to their disease, they just said, okay, it's just another side affected, so they didn't really bother them. Whereas the carriers almost unanimously thought of this as a catastrophe and were really afraid of the future. When you interviewed them after 4 months, the patients were kind of settled, so they were, like we call them, happy-go-lucky. If they had a good day, that was fine, and they didn't think more ahead than on a day-to-day basis. Whereas the carriers really found themselves as chaos coordinators, always on the watch and afraid of what was going to happen next. And this really aligns with the findings from the neurocognitive testing, where the capability of doing daily functions really deteriorated. Next one. But the most common question we got during the study was, why didn't you also scan my brain during follow-up? So that leads us to the part of screening for asymptomatic brain metastasis. Next one. So now I'm going to give the presentation that I had on this brain metastasis meeting in Paris in 2024. This is just a commercial for the 2026 meeting, which I recommend you to attend if you are interested in brain metastasis treatment. Next one. So why should we screen? So it's kind of obvious when you look at this statement that symptomatic brain metastasis develop from asymptomatic brain metastasis. So in order to have a symptomatic lesion, you have to have some asymptomatic phase before that. Next one. And the idea is to discover the lesions sooner so you can prevent or reduce symptoms and complications from the brain metastasis. You can possibly enable less burdensome local treatments like stereotactic radiotherapy instead of surgery and whole brain radiotherapy. And there are also the choice of systemic treatments, which are becoming more and more important. Next one. So what do the guidelines say? For lung cancer and melanoma, there's a standard almost for screening for advanced stages with brain MRI, both in the NCCN guidelines and in the ESMO guidelines. But for breast cancer, if you do the next slide, please, the recommendations are more ambiguous. So the NCCN guidelines state that you should do a brain MRI for stage 4 or recurrent breast cancer if there are suspicious symptoms. Whereas the ESMO guidelines, if you do the next slide, state almost the same. They recommend it for lung cancer and melanoma advanced stages. Whereas in breast cancer, it's potentially justified in HER2-positive and triple-negative disease. So there are no firm statements for screening for breast cancer brain metastasis. Next one. A study asking both physicians and patients on their attitudes against brain imaging screening for breast cancer brain metastasis revealed that most physicians do that, mainly when there is extracranial progression, or especially at HER2 positive and triple negative disease. And most of the patients would like to undergo brain images screening, especially the younger ones and those with hormonal negative disease. Next one. It is also found that more than 1 in 3 patients with HER2 positive or triple negative disease develop brain metastasis during the disease trajectory. Next one. And in a phase 2 trial with brain MRI surveillance, they did testing at baseline and at 6 months. And at 6 months, more than 1/4 of the patients, regardless of receptor status, were found to have brain metastasis. Next one. This was also the findings of this more elderly study, where asymptomatic patients more often had 1 brain metastasis, were less in need of whole brain radiotherapy, and more often could use HER2-directed systemic treatment after brain metastasis diagnosis. Next. And it was also found quite early that more than half of trastuzumab-treated HER2-positive breast cancer patients actually died of their progressive CNS disease, whereas the extracranial disease was controlled due to the efficacy of the trastuzumab treatment. Next. And as systemic treatments for breast cancer has developed, there are more agents with the CNS activity. This is just some of them, and that had really changed the landscape and the attitude towards brain metastasis treatment, and also as consequences of screening. Next one. This is quite nice summarized in 2 recent comments, one from Kasia's group, published in JCO recently, and one in the breast by the American group. And they confirm that screening detects frequently asymptomatic brain metastasis, which then are smaller in number and smaller in size, and therefore more eligible for stereotactic radiotherapy. And that the improved systemic treatments that have been developed may justify early detection of brain metastasis also in breast cancer. Next one. But then there's also the downside of screening, that you can actually afflict concerns to the patients. And then the term scan anxiety has turned up. That is the anxiety associated with the scanning for asymptomatic disease, regardless of brain metastasis or other diseases. So that also has to be addressed. So we did quite superficial study of our patients with lung cancer, melanoma, and breast cancer. Most patients that we included were symptomatic, but a small fraction were asymptomatic. As you can see, for breast cancer, it's a really small proportion of patients with asymptomatic disease, but we decided to look into that as well. Next one. So we asked them also for their symptoms at inclusion, regardless of symptomatic or asymptomatic discovery. And those with the symptoms, naturally, I would say, had more frequently headaches, communication deficits, sleep disturbance, and motor dysfunction. So they had more symptoms. Next one. There were no difference in survival between the asymptomatic and symptomatic patients. This is both patients with lung cancer, melanoma, and breast cancer. Next one. But looking at breast cancer separately, the asymptomatic patients more often can be treated with stereotactic radiosurgery or radiotherapy. They were less often in need of surgery, and they were less often in need of steroids. Next slide. This is just a brief SPSS analysis showing, quite surprisingly actually, that the HER2 positive patients did as bad as the triple negative patients after diagnosis of brain metastasis, whereas the HER2 positive patients really did quite well. And Kasia and her group has also looked at the incidence of brain metastasis in early stage breast cancer, that's stage 1 and 2 and 3. And as you can see on the graph on the right, on the left, sorry, the incidence really arises after a few years after primary breast cancer diagnosis for the stage 3 patients. What we have seen is that the median time from metastatic disease to development of brain metastases were 42 months in the HER2 positive group, 20 months in the receptor positive group, and 2 months only in the triple negative breast cancer group. So that can have consequences for the timing of screening. Next one. And this is a study that I discovered online before coming here. So this is a symptom study with Kasia as a PI, which I now understand is in review for publication. So that's really interesting. The study was active and not recruiting now online. So what should now be the next step? And as you can see, I've been giving this some thought during the years. So my own suggestion just before looking into what Kasia is doing is to do an interview study. Physicians are reluctant to screen for conditions that they cannot for certain know that there is a benefit for the patients to have screening. So they're afraid of inflicting anxiety and concerns among the patients. So one suggestion was to interview the patients that were offered screening for lung and melanoma disease, because they are screened already, and ask them how did they experience both the offer to be screened, how did they experience the screening itself, and waiting for the results, etc. And actually, this experience is one of the questions for the new study that Kasia is preparing. I also wanted to do a more follow-up of the whole brain radiotherapy-treated patients. And although whole brain is being used less and less, there's still patients being treated with that. So I wanted to interview them more in depth about how they felt and what kind of symptoms they have after the treatment. Next one. I think the next one is the last slide, actually.
I'm sorry, it's a little bit of a technical issue. I stopped advancing.
But I think that's the next to last slide, so that's okay. The next one was just what will you do now? So that could be a later discussion, I think. So thank you.
Okay, excellent. Thank you so much for that thorough overview and going through the literature. I'll open it up to the group. If anybody has any questions, please feel free to use the chat box or raise your hand. I guess maybe with the first question, what's happening in Norway from your experience in terms of screening? As you outlined, the international recommendations around screening really do differ. So ASCO and ESMO do support screening patients for brain metastases if they have a high risk of developing them, so triple negative and HER2 positive population. But the ABC guidelines recommend against it, and NCCN doesn't support routine screening either. So what do you do in Norway, and how do you interpret these conflicting recommendations?
Yeah, that's a good question. And I asked my colleagues at our hospital, and they were really diverse. So some did it routinely, some didn't do it at all, some did it at some occasions, some did it if the patients asked for it. So I really think they're in bewilderness. They don't really know. So I think the answer is really we do and we don't. We don't have any common policy in Norway for that. But
Right.
but melanoma and lung cancer really follow the guidelines, so they do what's recommended.
Mm-hmm. Interestingly, in Canada, there's a relatively new group called the Real Breast Cancer Alliance, and the group we're generating consensus recommendation for optimal therapy for breast cancer patients in Canada. And in the HER2 positive recommendations, this was published very recently, I think also in February, we do make a recommendation for screening for brain metastases. But because we don't really know the details in terms of, well, how should we screen, how often, we took a pragmatic approach and recommending, based on expert consensus, that patients with newly diagnosed HER2-positive brain metastases, there should be a strong consideration for screening and at the time of extracranial progression. But I think that would be another interesting study, as we chatted just before the session, evaluating whether routine screening every 3 months or just that initial diagnosis and extracranial progression. And I think that would be quite informative. But these screening trials are difficult to do.
Yeah, and I think one of the arguments against screening, at least among my colleagues, were why should you scare patients with the possibility of having brain metastasis when, as a general population, the risk is not that big. However, I think the patients are really aware that this can happen anyway. They discuss among themselves and they really ask, why do we not do it? And there could be a good answer why we shouldn't do it, but we don't have that good answer yet. And the answer could also be we should do it. So I think the only way to really find the best answer is to do some studies on it. And what's the best study? As we discussed, that's difficult.
Right. And notably, just because you had mentioned the anxiety, there's a group in Europe, Dr. Ilana Lachman from Germany was one of the lead investigators on the survey-based study that included patients and also physicians in Europe, and we participated in Canada. But they found it was quite interesting that the patients who were surveyed, they didn't really feel that they would be bothered by the anxiety of doing an MRI. They in general wanted to have it done. But like you said, it's individual. Some people might feel nervous about doing an additional MRI scan, others may not. So something perhaps to discuss with the patients.
Absolutely.
Dr. Chow, I think I saw you unmuted. Do you have a question?
No.
We can't hear you, Edward. I don't know if...
I do not have question.
No question? Okay. So then maybe as a final question, unless somebody else wants to put something in the chat or unmute themselves, I'm curious about the next step that you have outlined, the interview-based study for screening and whole brain radiotherapy. Is this something that's already, is it currently in the plans or something that's close to opening? And how do you plan to organize the study? And are you interested in an international collaboration with us in Canada?
Well, to the last one, yes, absolutely. To the other ones, I have to say, I'm sorry to say that we are not that far in planning the study, but since things have settled a bit now, I think this study can be done with not that much funding also. So we have a very strong group that can do interview studies in our research centers. So I think this is the whole brain thing is the most easy thing to do now. We do actually do quite a bit of whole brain at our institution. I don't know if that's the right policy now, but still we do it. So I think it's important to ask patients, and our management is also stressing that we should rather do 4 gray times 5 instead of 3 gray times 10, to increase the capacity. And I think for the patients that will mean a higher load for each treatment and maybe more symptoms afterwards, but we don't know. For the interview study, especially for the lung cancer and melanoma patients, that's the same thing. I think it could be quite a low threshold to do that. But for breast cancer patients, it should be following such a study, at least to be accepted in our institution, I think. But certainly I would like to cooperate if that's a possibility.
That would be interesting. I mean, there's a couple of radiation oncologists who are interested in brain metastases at our center, so I'm happy to make introductions to see if we can work together on that topic.
Great, thank you.
Great, excellent. Well, thank you so much again, Dr. Erich, for joining us and for the excellent presentation. I think given that we are now close to 12:45 and people have had some opportunities to ask their questions, we will call it a day and maybe give you some opportunity. I'm sure you're looking forward to further travels around the city and exploring. Yeah. But thanks again so much for your time and for joining us.
Thank you so much for having me.